All right, Dr. Kehinde Elisha speaking here. Today is April uh, 13th or 14th. I lost track of time. We're going to be getting started, but 2025 in a nutshell. We're going to be getting started with five body systems at a time for clinicians. The first one we're going to talk about right now is going to be what? Cardiovascular system. So when we talk about cardiovascular system, what is the focus of cardiovascular system? You want to, first of all, take note of the pathology under each of the systems. We're not really covering all of the pathophysiology right now, just picking the high yield ones: myocardial infarction, atrial fibrillation, post-op cardiac surgery, and that's it. So now let's quickly go ahead and talk about heart failure. So heart failure, what do you want to watch for? You want to monitor for signs of fluid retention, edema, weight gain, jugular venous distension, dyspnea, fatigue. That should be your focus whenever you get any case about somebody with heart failure. So how do you manage the patient? Definitely you want to prioritize the use of diuretics, for fluid remover, ACE inhibitors or ARBs, for vasodilation and beta blockers, example metoprolol, to improve heart function. What exactly are the complications that may arise with a patient that goes through or that have heart failure? They may go through, electrolyte imbalances. Their kidney may take a hit. So we have to keep eye on all those levels by monitoring the appropriate labs. Especially, you're going to be giving furosemides, right? So that alone, what does it do to our potassium? We just learned in pharmacology that furosemide, in fact, will cause what? Hypokalemia. Now, hypertension, what do you want to assess? You want to monitor blood pressure. You want to check for target organ damage like kidney failure, retinopathy. Lifestyle modifications. You want to check, you want to see if they are doing exercise or encourage them or educate them. If they smoke at all, tell them to stop smoking. Here we're talking about hypertension. Those are the things we have to modify to get our heart back in order. We can never get it to work normally again, but at least we can slow the progression of the disease. Usually, what do we prescribe for somebody with hypertension? ACE inhibitors, calcium channel blockers, and so on and so forth. When somebody has hypertension, what do you want to monitor and watch them for? You want to ensure they don't have a stroke, heart attack, or what? CKD, because it's a possibility that you're going to end up having this end organ damage. What about myocardial infarction? Myocardial infarction, what do you want to assess for? You want to make sure that you have your EKG in order. You want to assess them for chest pain, any diaphoresis, shortness of breath. Does it make sense? Do you notice that for every pathology, there are things that we kind of like focus on or care about? What we care about also determines what kind of questions we ask. So how do you manage somebody with MI? Definitely manage with aspirin, oxygen therapy, morphine, nitroglycerin, of course, to relieve pain, and of course, morphine to relieve pain and for vasodilatory purposes. And of course, somebody with MI, how do you care for them once after they go through it? Secondary prevention with statins, beta blockers. Type in the chat if you understand why we call this secondary prevention. Why do you think secondary prevention is going to be beta blockers and statin? Okay, just in case you don't know, primary prevention is we need to prevent it before it even starts at all. Secondary prevention is, well, it's already here. We're going to do whatever we want to do to make sure to slow down the progression. Now, let's talk about atrial fibrillation. Assessment. You want to assess for what? Heart rhythm, symptoms of palpitations. Are they dizzy? Are they having shortness of breath? So how do you manage somebody with AFib? Definitely you want to control the rate with beta blockers, calcium channel blockers. You want to do anticoagulation therapy. Don't forget, somebody with AFib, they have a high risk for what? For blood clot. So you want to consider what? Warfarin or direct oral anticoagulants. That is what we call in short DOACs. That's what we call DOACs, right? To prevent stroke. Complications. There is a risk for stroke due to emboli formation. When you think about AFib, when you get any question about AFib, think stroke. Now, what about post-op cardiac surgery? Monitor for bleeding, infection, and graft patency. Management, post-operative monitoring, of course, vital signs, chest tube output, and of course, cardiac rhythm. Complications. You better be alert and pay attention. Are they having any cardiac tamponade? Are they having any arrhythmias? So we have pathophysiology of the heart, but for every pathophysiology too, there are things we have to observe for and monitor for. The next body system is respiratory system. The very first thing we're going to talk about with respiratory system is asthma. Don't forget, there are guidelines that we follow to manage asthma. It's called the GINA guideline. Similarly, there are guidelines that we follow to manage COPD guideline. It's called the GOLD guideline. For everybody's system, there are guidelines. We just don't do guesswork. We go by these guidelines to know exactly what to do. So how do we answer somebody with asthma? You want to check. Do they have wheezing? Are they coughing? Do they have shortness of breath? What is the peak flow reading reads? You have to kind of understand how to learn to read your peak flows. You want to know the concept that goes with that. That's a different learning for another day. But how do we manage asthma? Rescue inhalers like albuterol. Albuterol falls under the category called SABA. That is the what? Short-acting bronchodilator. Short-acting beta agonist. Okay, sorry about that. And of course, for acute episodes, that's so it's short-acting. It kicks in really fast, gets their airway open. That's what we want. And we can also do like inhaled corticosteroids like fluticasone for, of course, long-term control. But something that we need for immediate use is going to be albuterol. Education, you want to encourage regular peak flow monitoring. You want to avoid any kind of triggers, things that will cause them to flare up, like pollens, like dusts, like pet air, and things like that. What about COPD? COPD is called what? Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. And that is, of course, how do you assess when somebody has COPD? You want to see, do they have chronic cough? Are they having sputum production? Do they have any shortness of breath? Are they wheezing? You want to manage by telling them you got to stop smoking so this doesn't progress. You may also want to administer bronchodilators like albuterol, like ipratropium, long-acting beta agonist, and that is called LABA. When you hear LABA, it means long-acting beta agonist. Does it make sense? So oxygen therapy, and of course, as indicated, you want to educate the patient. Education. For every exam level, you have to learn to educate. They will test your skills also as providers to see if you know how to educate. And don't forget, even if you want to delegate education, you have to know who to delegate it to now. You can delegate it if you're already educated and you want to re-educate. So encourage pulmonary rehabilitation, breathing techniques. Tell them to do a pulse-sleep breathing, to take it easy and take it slow. COPDers, don't forget, they are breathing through what? Hypoxic drive. We want them to be what? To have a high CO2. Does it make sense? That is their hypoxic drive. So you don't want to give them too much oxygen either. If the oxygen is beyond 6 liters, it might they might stop breathing. It's just not good for them. We don't want them on a high oxygen to that level. It's going to diminish their breathing, their drive. Now, what about pneumonia? Assessment. You want to see, do they have fever? Do they have chills? First of all, what is the pathophysiology of pneumonia? We did pathophysiology yesterday, right? With pneumonia, we know that it's a bacteria. It's caused by bacteria, right? So they're going to have fever, chills, cough, dyspnea, right? Management, you want to administer appropriate antibiotics based on culture results, like ceftriaxone, azithromycin. You must know your drugs and know your class. For every kid, there is a mother. For every drug, there's got to be a class. So you have to understand your drugs and your class. You must understand your content for this exam. I know students want questions. Please don't be part of those people chasing questions around. None of those questions will ever be on your exam. Stop wasting your time and stop wasting your money. Stick with the content, try to understand it, bring up some real life experiences and make the connection. Now, supportive care. You want to encourage what? Fluid intake. You want to monitor oxygen levels. You want to provide oxygen therapy. What about pulmonary embolism? See, all these cases, they are not really outpatient care. You will see a lot of this inpatient. If you work in ICU or med-surg, you will run into them. Now, what about pulmonary embolism? Automatically, you know it's a clot. When a clot breaks loose and goes into the head, it's called a stroke. When a clot breaks loose and goes to the heart, it's called a heart attack. So however we see clot, we don't want it happening to us because it can lead to something really, really chronic and bad. So assessment, sudden shortness of breath, chest pain, tachycardia, hemoptysis. How do we manage somebody with pulmonary embolism? You want to administer anticoagulants like heparin and warfarin. You want to provide oxygen therapy for them as well. What are the complications that can arise when somebody have pulmonary embolism? Definitely you want to be monitoring for bleeding and hypotension Because don't forget too, we're giving them anticoagulants, right? So they're going to have side effects from that. In addition to other complications, of course, it is stroke, right? That may happen when the clot breaks loose. We have something called HERDS. What is HERDS? So HERDS is acute respiratory distress syndrome. How do we assess somebody with RADS, with ARDS? You want to see they're gonna show up or present as someone with rapid onset of what? Severe shortness of breath, hypoxemia, diffuse pulmonary infiltrates. How do you manage them? Of course, ventilator support, low tidal volumes. You want to put them on a prone positioning. You want to you want to help them improve oxygenation, corticosteroid for inflammation. What about complications? Focus on preventing ventilator-associated pneumonia and barotrauma. Now, the next body system is going to be what? Neuro system. We're on the third system now. But can you see how we pick the quick facts? That doesn't end it. You still want to go to Canvas and ensure what? That you are going through the detailed content. This is not it, but this is a good place to start and repeat and repeat and repeat. And you can get through this system in 30 minutes and know that, okay, I know something. Now it's time for me to branch out. So this is more of a foundation for you. So with neuro, can we go through with neuro? Stroke, seizures, Parkinson's disease, multiple sclerosis, and meningitis. Now with stroke, what do we see with stroke? What are the assessments with stroke? There is something called FAST. What is FAST? That is the face, that is the arm, that is the speech, and that is the time. We must assess for this. Once we see that stroke is really taking place, we need to get them to acute care center ASAP. Why? Because TPA must be timely. It has to be given between 3 to 4.5 hours. Anything outside of these, the tissue plasminogen activator cannot be given. It's not going to be effective. So for long-term care, focus on antiplatelet therapy and, of course, rehabilitation. Let's also be very, very careful. There are two main types of stroke. We have what? Hemorrhagic stroke, and we have the embolic stroke. If it is an embolic stroke, it's all about clots. So we're going to try and declot. We're going to try and do a clot, but we're going to try and do a clot buster like with a TPA, right? If it's hemorrhagic, we don't want to be doing the TPA for someone that is already bleeding. You know what I mean? They're gonna bleed to death. So we got to be careful. What about seizures? Assessment. Note the type of seizure, tonic, clonic, absence, etc., duration, and post-ictal state. Management, you want to protect their airway. You want to administer anti-epileptics. Of course. What are your anti-epileptics? Like phenytoin, like levetiracetam. You will use it to suppress the electrical activity in the brain to help to keep them from having seizures. You want to ensure patient safety during these episodes. How do you educate somebody with seizures? Educate them. First, they have to stay safe. They have to know what the trigger is and avoid it. They have to make sure they patch their side rails. And even you, if you work in an acute care setting, that is one of the things you're going to do. You want to make sure that you are patching their side rails so that they don't go into seizures and then bump their heads on those little hard surfaces. The next disorder under neuro that is frequently tested is Parkinson's disease. How do you assess somebody with Parkinson's disease? They're going to have bradykinesia. What is bradykinesia? Bradykinesia means slowness in movement. They're going to have tremors. They're going to be so rigid. Postural instability. How do you manage somebody with Parkinson's disease? Of course, dopamine agonist. Don't forget, there are two neurotransmitters involved in Parkinson's, and that would be acetylcholine and dopamine. Acetylcholine and dopamine. You're like, okay, acetylcholine, but how though? Well, acetylcholine and dopamine have an inverse relationship. Acetylcholine goes up, dopamine comes down. Dopamine goes up, acetylcholine comes down. So what does that mean? When somebody when Parkinson's disease, their dopamine is down. As we treat them with dopamine agonist, when you see the word agonist, it means we're giving it to them. So we're going to bring up the level of dopamine. As you bring up the level of dopamine, guess what is going on? The level of acetylcholine is going to start coming down. When acetylcholine comes down, you may see a patient showing cognitive issues, because you are probably throwing them into dementia-like symptoms, like Alzheimer's. That's exactly what happens. Whenever somebody also have Alzheimer's, when you start treating them to bring up the level of acetylcholine, you're going to see dopamine tanking down. So you're going to see them shaking and having like tremor-like symptoms. That is why you're going to see our nursing home patients having most of these symptoms that I just described. you just can't win. You're fixing one, you're giving them something else. And that is exactly what life is about too. Somebody with thyroid issues, you fix one thyroid issue, you give another one. You fix somebody with diabetes, they may get hypoglycemia. I mean, yeah, they have high blood sugar, they may get hypoglycemia. They have hypoglycemia, they may end up with hyperglycemia until we get that balance, until we get it together. How do you now educate somebody with Parkinson's disease? Definitely, you want to encourage physical therapy. You want to improve, tell them to, find a way for them to improve mobility. And then monitor for dyskinesia. So a lot of times, whenever we have Parkinson's disease, it came from a brain part also called what? Basal ganglia. Basal ganglia is part of the brain that involves in movement. Any deficiency or any issue that we encounter with the basal ganglia, guess what's going to happen? We're going to start having some movement issues. Now, like bradykinesia, hyperkinesia, and dystonic reaction. Now, what about multiple sclerosis? Assessment, fatigue, muscle weakness, blood vision, numbness, right? So how do we manage somebody with multiple sclerosis? You want to use immunosuppressant like interferon beta, corticosteroids for relapses, and symptom management for spasticity. How do we educate somebody with multiple sclerosis? Stress the importance that they got to rest up. And of course, they got to manage fatigue as well, because they tend to, want to try to do everything. Then, of course, the flare starts all over again. What about meningitis? Meningitis is frequently tested and is going to be on every exam. Why is that? Because in America, we tend to see a lot of these cases. Whatever cases that we frequently see in clinics and hospitals is also going to be on the exam. So when you see meningitis, of course, it's some kind of infection, right? So you should expect some kind of fever, headache, stiff neck, of course, nuchal rigidity is one of the hallmark for what? Meningitis. Altered mental status, photophobia, right? How do we manage somebody with meningitis? Broad spectrum antibiotics like ceftriaxone, vancomycin. Don't forget to go through your content on antibiotics. Don't forget to understand your drugs and your class and be able to connect with it at any point in time. What complications can we potentially see with somebody with meningitis? We get to monitor for increased intracranial pressure and seizures. That is the thing. Whenever there is a shift in the brain, this is not an uncommon thing. We're now going to go to the fourth body system. That is psychiatry. You kind of see the way I'm doing things, right? I am connecting my neuro with psych, and then I'm going to connect my psych with what? What's the last one again? Endocrine system. All right? So that's kind of neuroendocrine, neuropsych. You will see that they connect a little bit. Now, with psychiatry, we have a whole lot of disorders, but we're just going to talk about the most common ones. And one of the first one that is very, very common is schizophrenia we're going to talk about. Now, schizophrenia, according to what a manual that we normally use in diagnosing the mentally ill, is called the Diagnostic and Statistical Manual of Mental Health Disorders, 5th edition. It was recently revised, so now we have a TR attached to it. When somebody has schizophrenia, what symptoms are we looking for? Do they have delusions? Are they having hallucinations? Do they have disorganized speech or any kind of negative symptoms? If they ask you on the exam, what are negative symptoms? See, there are two main symptoms that we see in somebody with psychosis. They are the negative symptoms or the positive symptoms. When we talk about negative symptoms, we are taking away from normal human experience. Positive symptoms, we are adding to normal human experience. So negative symptoms, what does that mean? It is flat affect. You look at someone, they're just looking sad and flat. Flat affect, anhedonia, avolition, right? Then what about the positive symptoms? With positive symptoms, we're adding to normal human experience. That is when we see hallucinations and delusions, loose association, disorganized. Those are all what? Positive symptoms. So positive means that instead of you sitting down in a conference, you get up and you start climbing on the table, climbing on the walls, talking to yourself. Those are positive symptoms. Negative symptoms, you give me a Tesla for my birthday. I'm just sitting down there looking all dull and sad. I'm not expressing any emotion. Those are all negative symptoms. How do we manage this patient? Of course, it is psychosis, right? You're going to treat it antipsychotic, like risperidone or olanzapine. We have a whole lot of antipsychotic. And don't forget, there are two main types of antipsychotic. We have the first gen and we have the second gen. With our second gen, they are frequently given and they have what? Less EPS side effects, like risperidone or olanzapine, quetiapine, clozapine, and so on and so forth. But then for the first gen, we have a lot of EPS happening with that. That is alloperidol, for example, very, very, very chronic with extrapyramidal side effects. Don't forget, extrapyramidal side effect is also an umbrella name with a bunch of concepts underneath it. Under EPS, we have what? Tardive dyskinesia. We have dystonic reaction, we have akinesia, we have akathisia, we have pseudo-Parkinsonism. These are all what? Extrapyramidal side effects. So when you say somebody have extrapyramidal side effects, be more specific as to which kind you're talking about. You must also understand your drugs and your class. Do you know what your first generation antipsychotic look like? Do you know what your second gen look like? Do you understand that it's your first gen that are very, very notorious for causing what? Extrapyramidal side effects? And then do you know that your second gen are notorious for causing what? Metabolic syndrome like weight gain, especially olanzapine. Well, they can also cause EPS if you use them for a long time. But extrapyramidal side effect is generally attributed to what? Our first generation antipsychotic. First gen is also called what? Typical antipsychotic. Second gen is also called what? Atypical antipsychotic. So they have like 2 to 3 names because they also have a chemical name that I'm not going to go into right now. SDRA, and we have DRAs. Now, what about the bipolar disorder? With somebody with bipolar, don't forget we have 2 mood states in life. Our mood can either be up here or our mood can be down on the dump. When your mood is up here for more than 7 days and you can't come back down, it is called bipolar mania. So with mania, you are like sleeping with everybody in the club, spending in all kind of ways, and if it can be combined too. And that's what we call bipolar depression, and that's what we generally use Lamictal to help support them. They may go through some kind of mood swings. They may be very, very impulsive. Speaking is Dr. Kehinde Elisha, founder of NP Certification Academy. To reach us, nurse-to-nurse-coach@gmail.com. To sign up for our review, visit www.npcertificationacademy.com or call 347-901-6037. This is not a free review. If you're in by any chance, please drop this Zoom and go back and make the booking. Be ethical. You have a long way to go in life. You don't want a little amount to hinder your success in life. We're now going to go ahead and continue with bipolar disorder. Management. Use mood stabilizers, lithium, valproate, antipsychotic for manic episodes, antidepressants, of course. Very carefully. Why is that? Antidepressants will throw our patient back into a manic state. So if we must use it, we have to be really careful using it. How do we educate our patients with bipolar? Of course, we're going to monitor for lithium toxicity, emphasize that it had to be compliant with their meds. Another psychopathology we're going to talk about under psychiatry is what? Depression. Depression, how do you assess somebody with depression? Are they persistently sad? Do they have loss of interest, changes in sleep? They may be hypersomnia or what? Insomnia. So they might be sleeping too much or not sleep at all. So it can be both ways. But there's something called the SIG-E-CAPS. The SIG-E-CAPS is just a mnemonic that we normally use in diagnosing our patients with depression. Once they have 5 of the symptoms, we're going to call it major depressive disorder. So how do we manage somebody with depression then? We're going to be using SSRI. What is SSRI? Selective serotonin reuptake inhibitor, right? We also have to be careful though, because they may get something we call serotonin syndrome or serotonin discontinuation syndrome. With serotonin syndrome, it can throw them into coma. With serotonin discontinuation syndrome, you can think of that as a night shift nurse. How do you feel as a night shift nurse? You're going to feel so tired. You're going to feel so irritable. The symptoms that we see, you're going to feel like when they detach from serotonin, that is serotonin discontinuation syndrome. Serotonin discontinuation syndrome is not the same thing as serotonin syndrome. What about SNRI? That's called venlafaxine. Any drug under this particular class, guess what it's going to do? It's going to raise your blood pressure up. So you're going to be monitoring the patient for high blood pressure, like venlafaxine, duloxetine, right? Now, what about CBT? Well, we focus on 2 modalities in psych. We do something called psychotherapy, and we also do what? Pharmacotherapy. Now, psychotherapy, we're using words to actually heal people. And there are many types of psychotherapy depending on the kind of, diagnosis that we give to the patient. What about education? You want to monitor for increased suicidal ideation during early stages of treatment. Now, let's talk about anxiety. Anxiety is another psychopathology. Again, we're just glazing over this, okay? If I'm really teaching the psych MPs, the DSM is a little bit more broader than this. But right now, we're just kind of going through a little bit of it, just enough to get another specialty into, to understand some of the things that may show up. But psych is in fact deeper than this. What about anxiety? Excessive worry, restlessness, tension, difficulty concentrating, Management, you want to use SSRI or SNRI. Short-term benzodiazepine like lorazepam for acute episodes. We try not to do benzos because benzo definitely can be very, very addicting. So you want to definitely avoid it. And if you are on it, make it a short term, like 2 weeks. Does it make sense? So, and if you have to get your patient off of benzo, you must taper the dose. You must not take off benzo abruptly. It has to be weaned off. And then, of course, CBT. You want to educate somebody with anxiety how to relax, relaxation technique. Stress management, they just don't know how to manage stress. We have to teach them how. Suicidal ideation, of course. Direct questioning by suicidal thoughts and plans. Management, you want to definitely ensure that they are safe. Don't forget the Maslow's hierarchy of need. Abraham Maslow said, human wants, in fact, are insatiable. And that is correct. But as much as it's not insatiable, we must satisfy one particular one. Safety. Safety, extremely important. Engage in crisis intervention and consider what? Hospitalizing them if needed. And that's why you see some people, they are putting them on one-to-one, right? Just to ensure that they are safe. You want to educate them that there are resources that they can do or they can use for more support. Because they might be feeling suicidal due to some kind of issues that they just can't handle. Perhaps we have a place that we can take them to, refer them there for extra support. The very last body system we're going to talk about right now is endocrine system. When we talk about endocrine system, what are we talking about? We're talking about the diabetes, type 1 and type 2. We're talking about thyroid disorders, Addison's disease, Cushing's syndrome, hyperparathyroidism. All right. So now let's first of all go to diabetes insipidus, diabetes mellitus. So what do you want to do for them? How do you want to assess them? You want to definitely monitor blood glucose level, hemoglobin A1C. We don't want it to be more than 5.6, right? You want to watch for signs of hyperglycemia like polyuria and polydipsia. Management, you want to administer insulin for type 1. And of course, oral agent metformin will be appropriate for type 2. Okay, be mindful of that. Type 2, do oral like metformin. Type 1, do insulin. And you want to focus on dietary management, and they need to work out. You want to teach them how to administer insulin. You want to also monitor for hypoglycemia. Yes, you're treating hyperglycemia, but you can throw them into hypoglycemia, right? Now, thyroid disorders, hypothyroidism, symptoms of weight gain, cold intolerance, fatigue, you got to treat with levothyroxine. All right, weight gain with hypothyroidism. Hypothyroidism can also mimic depression. So you might be screening the patient for depression as well. Hyperthyroidism can mimic what? Anxiety. We have to they go hand in hand, okay? Symptoms of weight loss, tachycardia, heat intolerance. You got to treat with something we call methimazole or radioactive iodine. So now, what about Addison's disease? You want to assess, do they have fatigue? Do they have weight loss? Okay, so now let's go ahead and take a look at the Addison's disease. What do we see? Do they have fatigue? Do they have weight loss? Do they have hyperpigmentation? Now, when you know what to assess for, you actually know what questions to ask because you don't see everything, right? So, for example, fatigue is definitely subjective data. You're trying to collect two types of data here, right? Objective and subjective data, right? So now management, you have to administer hydrocortisone, fludrocortisone to replace cortisol and, of course, aldosterone. What are the complications of Addison's disease? You want to monitor for adrenal crisis, severe hypotension, hypoglycemia. What about Cushing's syndrome then? And what do you want to assess for with Cushing? Just think about the face has a lot of Cushing on it. Hopefully that will help you remember like a moon face, buffalo hump, like the back has a lot of Cushing in it, right? Then weight gain, of course. My body have a lot of Cushing on it. Sorry, not being stereotypical. I'm not a skinny person either. Just a way for you to remember, right? Purple striae. And management, gradually taper steroids, treat underlying causes, tumor resection, and of course, use metotane for adrenal carcinoma. Now, what are the complications of Cushing's syndrome? Monitor for hyperglycemia, hypertension, and osteoporosis. So with Cushing's syndrome, monitor for hyperglycemia, hypertension, and osteoporosis. Now, hyperparathyroidism, what are the symptoms to watch for? You want to watch for hypercalcemia. Example, kidney stones, constipation, bone pain. These are things we see with what? Hyperparathyroidism. How do we manage somebody with hyperparathyroidism? You want to do surgical removal of the parathyroid gland. You want to monitor hypocalcemia post-surgery, right? How do you educate them? You want to definitely encourage adequate hydration and calcium monitoring. Now, That ends the 5 body systems in just what? 29 minutes and 54 seconds. At this time, we're going to jump right on monitoring consideration. When we have cardiovascular system, what medications do we give? What drug interactions do we expect? And then what do we monitor as nurses or as APRN? So look, cardiovascular ACE inhibitors, so let's say lisinopril, right? What drug does it interact with? You have to know that it can interact with diuretics. What does it do? It's going to increase risk of hypotension, right? Increased risk of hypotension when used with diuretics. What about beta blockers? What is the drug interaction? When used with calcium channel blockers, there is a risk for bradycardia. When used with calcium channel blockers, there is a risk for bradycardia. Beta blockers, bradycardia, BMB. Beta blockers, bradycardia, right? What about diuretics, aka furosemide? When we use it with ACE inhibitor, what can happen? We can see hyperkalemia. Hyperkalemia itself, ACE inhibitor by itself will cause hyperkalemia. And then that's why we don't combine ACE inhibitor with ARBs, because they both will cause hyperkalemia. What about anticoagulants? When we combine with NSAIDs, we're going to see increased bleeding risk. Those are the drug interactions that we need to pay attention to. That is warfarin plus NSAID we're gonna have an increased bleeding risk. So by the time we know what interaction to get, we know exactly what to look out for, right? For example, now with ACE inhibitor, we know we're gonna see hypotension. You want to go ahead and monitor blood pressure and renal function, and like creatinine and GFR. With calcium channel blocker, you want to monitor heart rate and blood pressure. Check for signs of bradycardia, because we know that we're going to see bradycardia, right? With ACE inhibitor, you want to monitor electrolytes, urine output, and renal function. With NSAID, you want to monitor INR, PT, and ensure what therapeutic range, and observe for signs of bleeding. So in short, whenever you know what interaction you're going to get, whenever you know the side effect that you're going to get, automatically you know what to look out for. What about respiratory system? Let's talk about beta agonists, inhaled corticosteroid, leukotriene receptor antagonist. So beta agonists, for example, albuterol. When we combine them with beta blockers, we're going to see antagonistic effect of bronchodilation. So we got to monitor for what? Respiratory rates, peak flow readings, or the oxygen saturation. With inhaled corticosteroids, we know when we combine with any of the CYP3A4 inhibitors, which is a drug-drug interaction that can actually inhibit our drug and raise up the level of the drug to a toxic dose. Example, ketoconazole, it can increase the drug level to a toxic dose. So we got to keep eye on that. Now, what about your monitoring? Anytime somebody is on a, inhaled corticosteroid, they have a chance of having what? Oral candidiasis, and of course thrush, and then you have to also watch out for growth in children. Now, what about leukotriene receptor antagonist? Example, montelukast. Phenobarb would decrease the efficacy of montelukast. Phenobarbital would decrease the efficacy of montelukast. Now, assess for headache, abdominal pain, and behavioral changes in children. Assess for headache, abdominal pain, and behavioral changes in children. Now, what about neurological neuro medications like anti-epileptics? Example, phenytoin. Antidepressant, example, fluoxetine. Antipsychotic, example, risperidone. What can we see with this? The interaction that we can see with anti-epileptics when we combine with carbamazepine and anti-epileptics, we're going to see a decrease in phenytoin level. Why is that? Because carbamazepine is a CYP. Is an inducer, is what I should call it, just to keep it simple. Is an inducer, so it's going to decrease the efficacy of phenytoin. And that is another lecture for another day. Inducer and inhibitor lecture is a different lecture on its own, okay? So we got to monitor the serum drug level to avoid toxicity and observe for nystagmus as well as gingival hyperplasia. When somebody is taking what? When somebody is taking phenytoin, you want to watch out for what? Gingival hyperplasia. Now, what about antidepressants? With antidepressants, when combined with monoamine oxidase inhibitor, we're going to have an increased risk of serotonin syndrome. Remember, serotonin syndrome is like a PACU patient. They are sedated. They have respiratory depression and so on and so forth. So you want to monitor for serotonin syndrome, like agitation, hyperreflexia, tremors, suicidal ideation, right? What about antipsychotics? When combined with CYP450 inhibitors like fluoxetine, it's going to increase the drug levels. So don't forget, an inhibitor will increase drug levels, and inducer will decrease drug levels. Induce is to reduce. Inhibitor with letter HI means highway system is going to raise up the level of the dose. So you have to monitor weight, blood glucose, lipid profile, and extrapyramidal symptoms. Now, with psychiatric drugs, mood stabilizers, antidepressants, and benzodiazepine, when we combine mood stabilizer with diuretics, what do we see? We're going to see lithium toxicity. So you got to monitor serum lithium levels, renal function, and of course, thyroid function. With antidepressants, when we combine with monoamine oxidase inhibitor, we can also see what? Hypertensive crisis. And we have to really keep eye on that. Also, with monoamine oxidase inhibitors, when we eat foods like what? Aged cheeses, wine, and stuff like that, it's going to also throw us into a hypertensive crisis. And we also have to monitor for what? Serotonin syndrome, suicidal thoughts, and of course, any kind of mental status changes. With benzodiazepine, don't forget it works on the GABA receptor site. Alcohol, by the way, it also enhances CNS depression. And what neurochemical is increasing in alcohol? We definitely see increase in GABA also with alcohol use. So that is sedation right there. So we got to keep eye on the respiratory rate, because the respiratory rate is prone to getting what? Getting depressed to the level of sedation. So we got to also watch out for signs of overdose. What about the endocrine system? The endocrine system, insulin, oral hypoglycemics, thyroid hormones, corticosteroids, calcium channel blockers. These are drugs that we have to now pay attention to for any national exam when it comes to endocrine system. When we combine insulin with beta blockers, what do we see? It's going to mask hypoglycemia symptoms. Beta blockers are the drugs that ends with LOL, like beta blockers. So if you're taking beta blocker and you don't check your blood sugar periodically, you may have diabetes and you may never know it. So you got to monitor blood sugar levels, signs of hypoglycemia, and insulin injection sites. And of course, what about oral hypoglycemics like combined with alcohol? It is going to increase the risk of what? Lactic acidosis. Automatically, really metformin by itself will increase the risk of lactic acidosis, but when we combine with alcohol, it's going to even make it even faster, right? Now, you got to monitor for renal function, liver enzymes. You want to monitor for serum glucose levels. Now, what about thyroid hormone? Thyroid hormone example, levothyroxine. When we combine with iron supplement, it's going to decrease absorption of thyroid hormones. When we combine thyroid hormone with iron supplement, it is going to decrease its absorption, right? So we got to keep what? Monitor the TSH level. We got to monitor the heart rate. Signs of hyperthyroidism have to be kept monitored. We also have to monitor for tachycardia and tremors. What about corticosteroids? Corticosteroid like prednisone, when we combine it with NSAIDs, we know there is a risk for GI bleeding. NSAID by itself can actually, induce that bleeding and ulcers. But whenever we actually now combine with prednisone, it's going to make it even worse. So we got to monitor blood sugar also, as well as fluid retention and signs of infection. What about calcium channel blocker? When we combine with grapefruit, don't forget grapefruit juice happen to be what? An inhibitor. It's going to elevate the level of anything that will combine with it. So if your patient is on grapefruit anything or grape juice anything, be careful with what drug they are taking at that moment, because it's going to elevate it to the toxic dose. So we got to keep blood pressure monitored, because amlodipine will work more than it should, right? So that means the blood pressure will be lower than you want it. Heart rate and signs of edema must be kept monitored. Now, the next thing we're going to quickly take a look at, this is the drug-drug interaction that we just talked about. And then we have a case study here. All right, thank you so much for giving me your attention today. Dr. Kehinde Elisha speaking here. That was just a quick and dirty 5 body systems, something you can listen to over and over and catch something to help with your board exam and at the exam at any level. That is all important. And if you are finding it difficult to get connected to the big content, just go ahead and get started right here. I have done this in less than 40 minutes, okay? This is 5 body system. This is not everything you need to know. My cardiovascular system alone is over 2.5 hours, okay? But now I'm doing cardiovascular system, respiratory system, psych, neuro, and endocrine in 40 minutes, less than 40 minutes. That means I'm missing out a lot, but then it contains a lot too. I just wanted to be able to circle around it many times. That's exactly why I left it the way that was why I did it the way I did. So if I'm too fast for you, start this video and pause it, start and stop. But hey, don't forget to definitely, spread the word for us, please. Our Facebook is right there. Our YouTube is right there. Check it out. And of course, connect with us. Spread the word. We have 99.9% pass rate, and we take a lot of pride in it. Our contact is right there, 347-901-6037. You may leave a voice note by clicking here, info@npcertificationacademy.com, or email nurse-to-nursecoach@gmail.com, and that is www.npcertificationacademy.com. Again, what reviews do we offer? PMHMP, FMP, AGMP, AGACMP, and of course NCLEX. And we also have some expert courses. If you pass your board exam already, you can come in here for further networking, to be proficient before you go start your job. So we look forward to, of course, connecting with you on at any level, whether a student or as an expert. And you come in here, booking is pretty easy. If you want to, let me say, click on NCLEX, you can click on it, click on Premium, which is the most popular. It takes you right there. You click on Book, and then it gives you the date that you're about to book. You click on Continue, and that is it. I really hope this is going to be helpful for you, and that it's going to help you connect with the body systems and what is most important to know for board exam. Have a wonderful day, everybody. Speaking here is Dr. Kehinde Elisha, founder of MP Certification Academy, 347-901-6037. Thank you so much for joining us today, and have a wonderful day.